Hello, welcome back to Dental Notes and Mnemonics. Today we are going to discuss about the Class II Malocclusion. So without any delay, let's get started with the video. Class II Malocclusion, as per Engel's classification, is a type of malocclusion in which mesiobuccal cusp of maxillary first permanent molar occludes anterior or mesial to buccal groove of mandibular first permanent molar. So the upper molars are positioned ahead of the lower molars in class 2 malocclusion. If it is shifted half a cusp width forward about 3.5 millimeter, it is called half cusp class 2, which is less severe. When the upper molar is shifted one full cusp width forward around 7 millimeter, it is termed the full cusp class 2, showing a more pronounced discrepancy. On the basis of the incisor position, class 2 is further divided into two types. The first is div 1 or division 1, where the upper incisors are proclined with an increase overjet, and division 2, where the upper incisors are retroclined, usually associated with deep bite and reduced overjet. Vendor Linden further classified class 2 div 2 into three types, type A, B and C. In type A, both the central and the lateral incisors are retroclined, but the inclination is not very severe. In type B, the retroclined central incisors are overlapped by lateral incisor, producing a characteristic appearance. In type C, both the central and the lateral incisors are retroclined and overlap with canines, creating a more complex anterior crowding pattern. It's not necessary that class 2 may be present bilaterally in class 2 malocclusion. Sometimes it is asymmetric. We use a term subdivision. That means the class 2 molar is on one side, on the other side is a class 1. It is named after the side showing class 2. For example, class 2 division 1 subdivision right means proclined incisors with class 2 molar on right side, while subdivision left indicates a class 2 relation is on the left side. Like any other malocclusion, class 2 malocclusion arises from the combination of genetic, developmental and environmental factors. Genetics causes include jaw size, tooth size discrepancies, skeletal disharmonies and familial traits. Developmental factors includes the disturbances in the tooth eruption, premature loss or prolonged retention of deciduous teeth, and anomalies in tooth number, size or shape. Environmental influences such as thumb sucking, tongue thrusting or mouth breathing, trauma and faulty dental treatment also play a significant role. Thus, in short, genetics sets the foundation, developmental shapes it and environment modifies it. So class 2 malocclusion begins with the patient history, where division 1 is often linked with the habits such as thumb sucking, mouth breathing and tongue thrusting, while division 2 usually lacks such habits. Extraoral features in division 1 includes a convex profile, lip incompetence and marked overjet, whereas division 2 shows a straighter profile, competent lips and sometimes a prominent chin. Intraorally, division 1 presents with proclined upper incisors and increased overjet, while division 2 shows retroclined upper centrals, proclined laterals and a deep bite. Skeletal analysis reveals that both divisions commonly have a retruded mandible, but division 1 is associated with vertical growth and increased A and B angle, while division 2 has horizontal growth with reduced lower facial height. Soft tissue findings highlight lip trap and difficulty in closure in division 1, contrasted with competent lips and lower lip resting behind the retroclined incisors in division 2. Radiographically, division 1 demonstrates proclined incisors and a steep mandibular plane, whereas division 2 shows retroclined incisors and a low mandibular plane. I think here it is important to explore more about the cephalometric use in class 2 Div 1 patient. We'll cover this topic under the four headings: the dental, skeletal, soft tissue and the growth status. Skeletally, SNA angle is normally 82 degree, is often normal or slightly high, while SNB angle normally 80 degree is reduced, giving a ANB value more than 4 degree. Similarly, the width appraisal normally, which is 0 mm in males and -1 mm in females, is shifted to more than 2 mm, confirming class 2. Vertical assessment with the Frankfurt mandibular plane angle is normally, which is 25 degree, and helps to identify vertical and the horizontal growth patterns. The dental parameters in class 2 malocclusion, the upper incisors and the NA, linear and angular measurements are normally 22 degree and 4 millimeter. This value is increased in division 1 due to proclined upper incisors and reduced in division 2 due to retroclination. The interincisal angle, which is normally 130 degree, is less than 120 degree in division 1 and more than 135 degree in the division 2. Class 2 treatment, the growth pattern is determined by the values SN, gonion, gnathon, FMA angle and Y-axis angle. It indicates vertical growth pattern when these values are high and horizontal growth patterns when these values are low. Lower anterior facial height also helps as it is increased in the vertical growers and normal or reduced in horizontal growers. In class 2 malocclusion is important for timing and planning the treatment. It is used to assess the skeletal growth on a lateral cephalogram by examining the shape and concavity of cervical vertebra from C2 to C4. Early stages from 1 to 2 indicates a prepubertal phase with minimal mandibular growth. Stage 3 to 4 corresponds to mandibular growth spurt with the maximum mandibular growth potential. And stage 5 and 6 indicate post-pubertal completion of growth. CVMI helps clinicians to time functional appliance therapy in class 2 for optimum treatment outcomes. Soft tissue analysis shows a convex profile with the upper lip ahead of E line and a reduced nasolabial angle less than 102 degree in division 1. Functionally, division 1 is associated with abnormal habits like mouth breathing, tongue thrusting, while division 2 usually have normal function but with stronger lower lip pressure influencing the teeth position. Class 2 malocclusion treatment depends on the patient age, whether the problem is dental or skeletal. In pre-adolescent children, minor dental issues like crowding, spacing, and rotations are managed with removable or limited fixed appliance therapy, while the skeletal problems are addressed with growth modifying appliances like headgear or palatal expanders for the maxillary access and functional appliances like twin block or Herbst for the mandibular protrusion, ideally during the peak growth period. In class 2 div 2, retroclined incisors and deep bite are corrected first with proclination and bite opening appliances. In the early permanent dentition, treatment becomes more comprehensive with fixed appliances, interarch elastics, and sometimes selective extraction for moderate skeletal discrepancies, crowding, or aesthetic concerns. Treatment also addresses transverse problem first using palatal expanders to provide stable arch, followed by vertical corrections for deep bite and open bite, and finally refining the anterior posterior relationship. In adults, growth modification is no longer possible, so treatment relies either on dental camouflage for the mild skeletal discrepancies or surgical correction, which include Lefort 1 osteotomy or mandibular advancement surgeries for the severe cases. In class 2 div 1, treatment focuses on reducing the overjet and alignment of the forwardly tilted upper incisors, often using functional appliances, headgears, or braces. Extraction may be needed for severe crowding. In division 2, the main concern is the deep bite and the retroclined upper incisor. Here, bite opening mechanism, fixed braces, and vertical control are the key, while the extractions are less commonly required in division 2. Essentially, division 1 is about overjet correction and division 2 is about bite and incisor inclination correction. Now, talking about the management of class 2 subdivision, then it focuses on correcting the asymmetry while achieving a functional and aesthetic occlusion. In patients, treatment is aimed at growth modification using functional appliances like twin block, fixed functional appliances. For adolescents and adults, dental camouflage is preferred, whereas asymmetric mechanics like unilateral premolar extraction, elastics, and temporary anchorage devices or molar distalization are used to correct the midline deviation and achieve a class 1 canine relationship. When the skeletal discrepancy is severe with marked asymmetry, orthodontic surgery such as mandibular advancement, asymmetric mandibular correction, or bimaxillary surgery is required for definitive correction. Finally, in all the cases, retention is essential to maintain the corrected midline and prevent relapse using either removable or fixed retainers. So this was all about the class 2 malocclusion, its type and its management. Hope you liked the video. See you in the next video. Till then, bye bye, take care, have a nice day, and don't forget to like, share and subscribe the channel.